Safety planning is a personalised set of coping and support strategies that are right for the person, that they can put in place at the time of onset or worsening suicide-related distress or suicidal urges. And safety planning is very much the thinking of the individual in discussion with their worker about the things that are right for them. And the idea about safety planning is that the more we put in place things that are important and helpful, the better that we become at using those techniques and those strategies when that crisis emerges. So we might start with things that are very much simple and easy and quick to put in place, right through to emergency care and right through to emergency rescue. There's very good evidence that safety planning technique is very helpful for people who experience suicidal crisis, and that evidence is telling us that there is reduced returns to the emergency department, particularly if you combine that with telephone support. One of the biggest and most important considerations is that this is not a contract. This is very much something that's co-designed with the help of your worker that's right for you. The conversations that we have are done almost in calm and relaxed circumstances, if you like. Then it's not a forced conversation to understand what's right for the person. So I can't give somebody a safety plan. We have to work at this together, and that's an important consideration.
I definitely believe that co-developing the treatment pathway is really important. Patient buy-in is critical to developing the right plan for that patient. Everyone is so different, everyone's mental health presents so differently. Through my own lived experience, I feel that it could have been done a lot better if I was more involved in that planning process and my family was involved, especially in the self-care exit plan when I left hospital. I think it could have really helped me a lot more, and it took me quite some time to develop a plan that I had a lot of involvement in.
Things that might make my situation safer, things that might calm me, things that might soothe me, people that I need to speak to. It might be some music, it might be some activity that makes my situation easier for me or distracts me or makes me feel better about a feeling state that I have at a particular time. And there must also be things that are achievable, things that are doable, things that are culturally appropriate, and things that are appropriate at times during the day or during the evening, and may in fact involve the support of family members. So lethal means restriction is a very important part of suicide prevention more generally, but fundamentally at the time of safety planning, discussion and co-design, lethal means restriction is about removing the access to those things that person, she or he, might imagine could be used to harm themselves. So what we're really having is an open discussion to remove those means, and it's recommended that you have that discussion perhaps with a family member who can support the person in distress. What I like most about safety planning is that it brings everybody's voices and perspectives into conscious play in a compassionate, thoughtful way. So for the person in distress, at risk of suicide or experiencing the onset or worsening of suicidal urges, it's an opportunity for them to be able to join with their partner or a family member, a carer, to be able to discuss what's right for them and share that discovery, if you like, about the things that are right for them, translate that to the written word, which is part of the safety planning. And I think there's a sense of shared voices, shared involvement, and shared learning, potentially, for those people. In the mix of all of this is your clinician, the worker, someone who carefully and thoughtfully and compassionately nurtures those conversations and enables everybody to come together. It's a coming together of the best thinking that's going to be right for that person.
I am aware that my family were consulted during my stay in hospital, absolutely. But I do think that it could have been more extensive, and it would have been more helpful for me and them if it was more extensive. My belief is that, a person who's gone through suicidal crisis definitely needs at least two people that know their plan, know what the warning signs are and triggers are for that person.
They need to move towards a no-blame culture, and they need to move away from traditions of the past. There's open communication, there's transparency, and there's flexibility. So for clinical staff, they need to know how and when to move in new ways to be able to accommodate that complexity and that personalised approach to, if you like, person-centred care. So to be able to enable person-centred care, that is fundamental in safety planning. So services have an obligation to really start to understand the person and their lived experience of using safety planning. Services have an obligation and a responsibility to support their staff for focused discussion, clinical supervision, professional support around safety planning. And I think services have an obligation and a responsibility to support their staff for what a quality safety plan looks like. So that's a cultural shift in the way that we think about suicide, the way that we engage our staff in professional development and clinical supervision. And indeed, it's a shift in the way that we organise our clinical governance framework and what we say, do, think and feel to be able to provide the best possible services for our staff and our clients. Well, fundamentally, we are going to share the learnings of what's happened. We're going to empower our staff. We're going to adopt a learning culture, a no-blame learning culture framework. When we bring all these elements together, we're really setting a platform for the best possible outcome for the service and the individual who seeks our service. The Zero Suicide Framework is, if you like, the banner headline for what is fundamentally a personalised way of supporting and comforting a person through safety planning. So the Zero Suicide Framework brings together our best thinking in suicide prevention. What is the best evidence that we can bring to the point of care, but also what is the best evidence that we can bring at an organisational level to be able to support people at risk of suicide. And Zero Suicide makes that happen. The beauty of the Zero Suicide movement is that it compels us to think beyond the person, but to think at the wider system and how evidence can be positioned in the right places for the people in our service.